Welcome to the Fuse Research Programme meeting, showcasing regional innovations in preparation for surgery, improving patient experience, health outcomes and efficiencies. So we're really grateful for everybody attending today. Obviously this is a virtual programme and we're very excited to be able to go through lots of short, punchy virtual presentations, which hopefully you'll find stimulating and will engage some debate in the final Q&A session. So just before I kind of say too much more, the clinicians, I want to say thank you to the clinicians and academics who have supported the programme. You can see all the names there, and the biographies, the full biographies I think are available on the Fuse website. But we've got people from a range of healthcare and academic backgrounds from across the region. From the delegate point of view, it's fantastic. We have about 85 to 90 delegates who are attending from a variety, again, of academic and clinical backgrounds, and excitingly from across the UK, which is really good to see. So just a few kind of brief points. As I said, most of the presentations have been pre-recorded with the aim of being around 8 minutes, although some people have taken liberties, but we'll let them off for that because other people have under-recorded slightly, but most are approximately 8 minutes. So thank you to the speakers for being diligent with their timekeeping, because I know that isn't an easy thing to do. After the first series of presentations at 10:15, we'll move into a question and answer session for 10 minutes, where we'll aim to take a variety of live questions. So if you have a question as a delegate or a speaker, if you raise your hand, we can take the question. That will be moderated by one of the facilitators and brought to my attention. And then you can also post your questions in the chat box. But we will keep that first session to 10 minutes because we then have a 10-minute comfort break between 10:25 and 35. From 10:35 onwards, we start with a live session with two people who have previously undergone surgery as patients. And I'll be facilitating a 20-minute kind of experiences session. And then that will be followed by the rest of the programme. And then at 11:25, we'll take our final Q&A and summary before closing at 12 o'clock. So that's pretty much all I want to say about the programme. If we could just flip on to the next slide, please. Just a few brief rules of engagement for everybody. Delegates and speakers, please. Ensure your microphone is muted and remain so unless you're invited to speak. Stop your video if you're not live streaming, just because, well, or asking questions, I mean, just because it'll improve the quality of the experience for everybody. As I've said, you can type your questions in the chat box, or you can raise your hand if you would like to ask a question. Fuse have put professional conduct as expected. I'm not entirely sure what that means, so I'll leave that to your interpretation. And you can see the last point as well, which I will also leave to your interpretation. So I think without further ado, we should move on with the programme. And what I'd like to do, first of all, is to introduce the first speaker, who unfortunately isn't able to join us today, but Chris Snowden is going to talk to us, about elective surgery reset, and that is about recovery from the pandemic. So Chris is a consultant anaesthetist at the Freeman Hospital, graduated from Newcastle University. He's been at the Freeman since 1997. His clinical interests are high-risk surgery, preoperative assessment, including perioperative rehabilitation and cardiopulmonary exercise testing. He has research interests in alcohol cessation and behavioural interventions and exercise training. Chris's overall work programme aims to promote the transformation of the anaesthetist into the broader base of a perioperative specialist Chris is also the National Clinical Director for Perioperative Medicine for the Getting It Right First Time initiative. So I can't think of anybody better placed to give this talk. If we can start the presentation, please.
Firstly, thank you for asking me to give this short recorded introduction to today's conference, showcasing just some of the exciting innovations that are being developed in our region. What I hope to do is to put a degree of context behind the presentations, which will hopefully be useful towards an understanding of where these initiatives will benefit the delivery of a better perioperative experience for patients undergoing surgery. I don't need to remind anybody on this conference that the pandemic has changed the entire healthcare landscape. At the beginning of March 2020, the severe ramifications of the decision to discontinue all elective surgery to allow hospital capacity to deal with the pandemic requirements were completely unknown. But fast forward a year to March 2021, and the magnitude of that decision is obvious. The exponential rise of patients waiting for elective hospital treatments. This first slide demonstrates the number of patients in the northeastern Yorkshire region waiting for all treatments for more than a year, a timeline that was almost unheard of at the start of the pandemic. Nationally, the figure in March 2021 stood at 300,000, and the northeastern Yorkshire figures mirror that national trend, making up 10 to 12% of those patients. It is important to notice the significant reduction in those long waiters over the last 3 months, which may give us some hope of modest recovery, but unfortunately, this doesn't tell us the whole story. Rather, the reality demonstrated obviously in this slide shows the rather depressing situation in terms of all patients waiting for hospital treatments. Here we see that the number of patients waiting for hospital treatments continues to rise, both in England, as shown by the orange line, and again mirrored regionally, represented by the blue bars. The UK figure is now around 5 million patients waiting, with around 700,000 of those patients being in our region. And this slide intimates the cause of the continual rise of waiting patients. The backlog of patients caused by withdrawal of elective surgery likely represents only the tip of the iceberg. Whilst we reduce the significant number of long waiters to a single category above 52 weeks, the constant stream of new referrals that were delayed and postponed for multiple reasons during the pandemic are obvious to see. Overall, the number of patients waiting excessively long periods for necessary treatments is eye-watering, and the wait times are totally unprecedented within the existence of the NHS. And if we look at the speciality mix of patients waiting, the majority of patients, some 60 to 70% of those patients, are waiting for surgical interventions. Whilst the medical specialties fare better in terms of their ability to incorporate virtual clinics and use digital methods in their clinical practice, the surgical specialties, where theatre capacity and manpower was still required, were particularly affected in terms of existing demand, being reduced by almost 40%, twice that of the medical specialties. So ultimately, what we have is a situation where demand, especially for surgical interventions, vastly outweighs the current delivery capacity. Importantly, meaning that patients are suffering not only from the harm not by receiving those beneficial treatments, but harm from deterioration in other conditions and comorbidities that coexist or indeed contribute to the illness. much has been made of the need to try and redress the balance by sweating existing assets, utilising existing capacity better, taking benefit from an elective recovery fund, delivering on planned hospital new builds, as well as close collaboration with the independent sector. But it's clear that this alone will not present us with an NHS that is fit for purpose in the future. Quite apart from elective recovery from the pandemic, there needs to be a much smarter reset of elective care. Revisiting existing practices, seen here by the greenstone on the right, removing unwarranted variation across the NHS and ensuring existing best practices are shared are all important service requirements to begin to redress the balance. But getting underneath the real barriers, the real issues that plague the NHS even before the pandemic to develop culture-changing innovations, and by posing new questions to ensure reset rather than just recovery, is the only way to move elective care forward. In more specific terms, and especially around delivering the elective surgical processes, it is a generalized view that we've been silo managing the perioperative process. Up till now, consideration of what goes on in theatre and around the acute perioperative environment has been the focus of most secondary care attention, with minimal consideration of the patient's whole pathway from primary care referral through to the appropriate discharge back into the community. This approach, ensuring much more in the way of system collaboration, must become a priority in our ongoing thinking. Ensuring that the correct patient is the right pathway, the right operation at the right time, and that every contact along that pathway counts in terms of patient experience. And as clinicians across the broad spectrum of healthcare sectors, but especially those involved primarily as secondary care providers, we also need to think even wider than that. The concept of how a patient lives well, both as an individual or within a population, is only the starting point to a much more complex series of transitional stages which aim to keep that person well throughout their interaction with the healthcare system, and includes many of the considerations noted here in the red circle. The final aim of making the individual live better has to be the ultimate goal. And finally, I'm sure you're going to hear much about this today, but some of the important realizations that have been exposed and revealed by the pandemic have to initiate some of the priorities leading towards a smarter reset, rather than just a hasty aim to recovery. Some of those realizations include the current reality of harm minimization will have to be converted back to one of harm prevention. There's a fine benefit balance between waiting population changing lifestyle and understanding treating a relevant perioperative disease, the massive importance of digital and virtual innovation, the recognition that not all care is equal and equitable, and the need to address this inconsistency now rather than later. And last but not least, the importance of collaboration and sharing of best practice for patient benefit rather than detrimental competition. So to conclude, my aim for this introduction was to contextualize the need to act positively to the surgical situation of long waiting times with a much smarter surgical reset. I know the exciting innovations and initiatives being presented today are the beginning of that most important change. Thank you for your attention.
Okay, so thank you very much to Chris Snowden for quite a thought-provoking first talk, and that's hopefully a really nice scene setter for the rest of the programme this morning. So next we're going to move on to a bit of regional showcasing for different, and we've themed this into different regions who are doing initiatives that we thought might be of interest to delegates. So we're going to start with South Tees, followed by Newcastle, followed by some work that's going on in Durham. And our next presentation of 3 from South Tees is from one of my colleagues, Dr. Rhiannon Hackett, who is a consultant anaesthetist at South Tees NHS Foundation Trust and is interested in perioperative medicine and prehabilitation before surgery. Rhiannon is a key part of the PrepWell programme, which I'm sure she's going to tell you about, and has been involved over the last few years from development through to where we have moved now with the pandemic. Rhiannon has also been co-leading the programme and has been particularly involved with the orthopaedic side of things. So I would like to pass things over to Rhiannon for her presentation, please.
Many thanks for the invitation to talk to you all today. I'm delighted to have this opportunity to be able to talk about the PrepWell programme. My name is Rhiannon Hackett. I'm a consultant anaesthetist based at James Cook University Hospital and clinical lead for orthopaedic prehabilitation at South Tees. PrepWell is a comprehensive multimodal prehabilitation service that is community-based and designed to support patients with behaviour change and to improve their health and well-being in the lead-up to surgery. It is a service that is led by Jerry Donju and run by a delivery team at South Tees Hospitals and Public Health South Tees. In addition, we have a number of partners across the healthcare sector and academia, including support from Northumbria and Teesside universities. We are a unique collaboration of health sector and academic partnerships and have developed a new model of integrated care across these sectors to provide care for patients. We are supported by Sports England through a local delivery pilot across Teesside called You've Got This. Typically, the programme consists of a multimodal intervention package that is agreed with the patient following their assessment on entry into the programme. We do an evaluation of their health status, risk behaviours and quality of life following a referral from either the surgical team or anaesthetic preoperative clinic once a decision is made to proceed with breast surgery. Patients are followed up following the end of their prehabilitation phase prior to surgery and at 3 months after discharge from the programme. Typically, the prehabilitation phase will consist of a structured exercise programme that is primarily delivered by public health trainers with physio oversight from South Tees. In addition, we also target other risk factors for surgery and offer access to lifestyle services through smoking cessation, alcohol reduction, nutrition, and mental health and well-being. Typically, we would aim for a patient to be within the programme for 6 to 8 weeks. However, this is tailored to their surgical requirements. In 2019, we successfully completed a pilot phase of this programme that was supported by the Health Foundation and Universities of Northumbria and York. What the pilot showed was that we were able to achieve high levels of patient engagement and satisfaction through the programme, with improvements in quality of life and observed sustained behaviour change for participants beyond the duration of the programme. Our economic analysis showed that the mean cost of the intervention was £52 per patient per week for an intensive prehabilitation package. And overall, our patients reported an overwhelming positive experience. Subsequent to the success of this pilot, we were then able to undertake a period of service review and development. We streamlined a number of different pathways for patients through the prehabilitation service in order to be able to offer an optimum package for different patients. The first of these is a high-risk pathway, which was targeted at patients undergoing major surgery or significant vascular disease, such as open aneurysm surgery, and for those patients requiring intervention for cancer. This was a bespoke package that was designed to be a more intensive and closely supervised programme for patients and was usually delivered face-to-face within a public health facility gym in the centre of Middlesbrough. The second of these pathways was a pathway designed for patients undergoing lower limb joint replacement surgery. These patients who were deemed to be low risk from a medical point of view and requiring a medicalised prehabilitation support package were entered into a pathway that accessed the existing regional health facilities through the exercise on referral pathway. Subsequently designed to be able to be a high volume pathway through use of these existing regional facilities. Thirdly, we began designing a digital pathway in order to be able to facilitate a patient self-managed option, supplement the low and high risk pathways for patients with a home-based option. In order to be able to do this, we commenced an industry collaboration with Go Well Health, which is an online platform delivering care packages for patients, which was already in use within South Tees for orthopaedic patients. Underpinning this development, we were able to expand our staff team within South Tees to include an exercise scientist and clinical admin support. Additionally, we developed a digital patient dashboard, which allowed us to monitor the service and evaluate it much more rapidly. And we were able to enhance our remotely supervised offer through the digital pathway and subsequently widen access across a larger geographical area and to more surgical specialties. However, in March 2020, as we all know, the COVID-19 pandemic resulted in the closure of gyms and the temporary pause of exercise on referral schemes, which meant we had to undergo another period of service review. Fortuitously, we had begun our industry collaboration with Go Well Health. This meant that we were able to rapidly redesign the service to become digital and to facilitate remote assessment and remote program delivery through the Go Well Health platform with development of a prehabilitation care package. We developed a cache of digital services for patients, including exercise videos and tutorials and online information for them to be able to access. In addition, the digital patient dashboard that was under development meant that we were able to remotely review the service and communicate with patients much more easily, despite the lack of face-to-face engagement. Currently, we deliver a high-risk pathway that has remained as a bespoke programme with access to the Go Well Health resources. In addition, patients are also able to access a schedule of classes online, which are health trainer delivered and remotely supervised through the MyZone and heart rate monitors by the team at South Tees. We've managed to embed this pathway into routine care for upper GI cancers and for patients undergoing aortic surgery. The orthopaedic pathway, which was launched properly in April of this year, is now offered to all patients registered on Go Well Health and has remained as a generic programme for low-risk medical patients with an increased focus on prolonged health behaviour change and support, given the impact on waiting times of the COVID pandemic. Both of these pathways continue to be underpinned by digital delivery. However, we do offer phone support and a paper-based programme for those patients unable to access digital services. We have also commenced another industry collaboration with Sapien Health, which is an app-based health coaching program that we are using to introduce prehabilitation to orthopaedic patients. And the preliminary results from this show excellent results and patient engagement. We've also recently launched a PrepWell website, which contains valuable resources for both patients and healthcare professionals and access to our PrepWell resources. So, moving forward, we are continuing to expand our service with a view to incorporating more surgical specialties in the coming months and years through the service. We are underpinning this with an ongoing evaluation of both the health impact and economic impact of prehabilitation within the South Tees Trust. Additionally, we are working with patients in order to be able to move back towards a face-to-face delivery when that is possible with COVID-19 restrictions, and also beginning to work on a potential peer support programme digitally enabled for patients to access. All that remains is for me to say thank you to the PrepWell team and to our partners and to our industry collaborators. Many thanks for your time.
Okay, so thank you very much to Rhiannon for an overview of the Prepwell programme being run in South Tees. Next up, we have one of our orthopaedic surgeons, Mr. Paul Baker, who is going to talk to us about digital joint school. I think it's fair to say that Paul is a slightly unusual beast in the orthopaedic world, in that he is very interested in kind of research rather than do an additional joint replacement here and there. Paul is also our Director of Research and Innovation at South Tees, and has been a great advocate for the Prepwell work that we're doing, which we're very grateful for. He's also the current Royal College of Surgeons lead for orthopaedic surgery. So I'm going to pass over to Paul now for a review of some excellent work that he's been doing with Digital Joint School.
The opportunity to speak at this FUSE event today. I'll be speaking about how we've managed to improve patient outcomes and experience using a digital education and support platform. Well, orthopedics is an area of innovation and great movement at the minute. In recent times, there's been a great deal of national guidance issued on how we should support our patients across the perioperative pathway, including guidance from the Centre for Perioperative Care, from the National Institute for Clinical Health and Care Excellence, and through the Getting It Right First Time initiative. The key messages from these groups are that we should embed shared decision-making and involve patients, their carers and their family throughout the care pathway. This must be inclusive for all people, including family members. Information must be presented in an understandable format that is related to the procedure being delivered. And we should undertake a pathway approach that is integrated with other services and demonstrates impact. The traditional method of delivering education and support to patients prior to hip and knee replacement is via a joint school. This is a face-to-face multidisciplinary event that typically occurs 2 to 6 weeks prior to surgery, in which information about the procedure and expected recovery is delivered to patients. We wanted to extend and expand that approach in a digital solution. We chose the GoWell Health platform to do this, as it has a significant functionality and a number of features that we found advantageous. It allowed us to upload our own content and create bespoke packages of information and care to patients that could be delivered in a timeline fashion. We can track our patients' engagement and integrate patient-reported outcome measurement and healthcare questionnaire collection. It seamlessly integrates with other services on the platform, such as our Prepwell Prehabilitation program, and we have the ability to invite family and carer members onto the platform as well. Care pack creation is really quite straightforward with GoWell Health. We upload the content to create a library, and then we can bundle those pieces of content together to create care packs. And this can include a variety of different multimedia formats, such as emails, videos, interactive forms, and documents. And this allows us to create a bespoke, individualized, tailored content for our hip and knee replacement patients. We've now been running this digital joint school pathway for about 3 years, and we're very keen to evidence the value of our approach. So we sought to undertake some work to look at how patients engage with the platform, to understand whether it enhanced patient experience, and the impact it had on patient flow and patient recovery after surgery. Patient engagement was assessed by analysing the data for the first 1,195 patients registered on the GoWell Health Digital Joint School. We typically offer registration to all patients listed in the hip and knee replacement. Overall, greater than 85% of patients registered activated their account. Engagement was high, of 15 accesses per patient. Patients, on average, spent just under an hour and a half looking at the content we had provided for them on the platform. Importantly, there was no difference in the number of interactions or the time spent on the platform dependent upon age or gender. Patients accessed the information provided to them across the day, as seen in the diagram on the top right. What we did see was a tendency for greater reliance on computer access from older patients and patients who are younger, typically accessing the platform via an app or a tablet, showing the importance of multimedia access points to help ensure engagement across age groups. Patient experience was assessed by undertaking qualitative interviews with patients that had used the platform. Our thematic analysis identified 3 themes around health behaviours, contribution of the platform to recovery, and the importance of patient education and support delivery. What we found was that our approach, the digital joint school, helped patients maintain control of their own health. They felt that the active nature of the platform with email prompts to look at information was important, and they were also very positive about the role of social support and the ability to invite family and carer members onto the platform to view their information with them. They were very positive about the quality and quantity of information provided, and they liked the fact that it was structured over a timeline over a number of weeks, so they weren't bombarded with information all at one time. We made a number of suggestions to improve their recovery, which they felt were positive. And they were overall very positive about embracing technology and digital platforms for the delivery of this type of information in the future. Finally, we assessed patient outcomes by looking at patients on Go Well Digital Joint School versus those not on the Digital Joint School over a 2-year period, initiating and integrating the service into standard care. This was done independently by an external academic partner who did the statistical analysis using robust statistical modelling to account for variation in characteristics between the 2 groups. And there were 3 outcomes of interest. We looked at length of stay, health utility, and joint-specific patient-reported outcome measures. The analysis of the patient outcome data is presented here. The raw data is presented in the table at the top, and the adjusted data correcting the differences in age, gender, and comorbidities are presented below. For length of stay, our hip replacement patients had a shorter length of stay if they were on the Go Well Health Digital Joint School, the size effect of just under half a day reduction in length of stay. We saw significant improvements in health utility at 6 months after surgery, both hip and knee replacement patients if they were on the Go Well Health platform. And similarly, we saw significant improvements in the Oxford hip and knee joint-specific patient-reported outcome measure if they were also on the Go Well Health Digital Joint School pathway. So the question is, why does this work? Why are we seeing such significant benefits with our digital joint school pathway approach? Well, our approach is aligned with the guidance that I've outlined previously from CPOC, NICE, and Best MSK. We support patients throughout the pathway, which is different to the traditional joint school, where patients are only seen as a one-off face-to-face appointment in the weeks before surgery. We deliver care at home. We don't ask patients to come back to the hospital for additional face-to-face attendances. Having set up the pathway, it runs almost autonomously. It's very resource light, and it has the ability to integrate with a number of other services that supplement our patients, provide additional value. And in addition, our approach allows us to collect data on patients in the form of patient-reported outcomes, health questionnaires that allow risk stratification, and it also prompts and reminds patients about the care they receive and how best to maximise their recovery after surgery. These quotes from patients from our qualitative interviews demonstrate some patient perspectives on our digital joint school approach and the importance of providing information in a format that they can understand, they can access, and that is provided from the point of listing until their full recovery after surgery. Thank you very much, and I'd be happy to take questions in the Q&A session later on.
Okay, thank you very much, Paul. So nearly at the end of the South Tees presentations now. Next, I would like to introduce Dr. Leah Avery, who is a health psychologist and an associate professor in applied health psychology at Teesside University. Leah has expertise in the development and evaluation of health behaviour change interventions. Our team are presently working with Leah, and she's going to talk to you about the work that we are about to undertake in the area of digital prehabilitation. So over to you, Leah. Thank you.
The evidence continues to accumulate supporting the use of prehabilitation interventions to improve both physical and mental preparedness for surgery. To date, these interventions have included things like structured exercise training and smoke and cessation and alcohol reduction programs. Despite several examples of successful face-to-face prehab programs, particularly those reported in the literature, only a small number of these exist for use during routine clinical care. And they often target single risk behaviours such as physical activity or nutrition, and frequently are not developed to meet the individual needs and preferences of pre-surgical patients. And unfortunately, this has negative consequences on uptake and engagement rates. Previous research conducted by a member of our research team has highlighted the demand for remotely supervised alternatives to centre-based programs. So James Duran's discrete choice experiment was able to report that over half of patients consulted reported a preference for a digital prehab program to enable them to prepare for surgery at home. However, there are currently no rigorously developed digital prehab interventions available for use in routine care, and the COVID pandemic has brought this unmet digital intervention need sharply into focus, where we've seen a number of examples of clinical teams having to very rapidly reproduce intervention materials for remote delivery at home to support patients. The aim of our research is to systematically develop and test an evidence and theory-informed multi-behavioural digital prehab intervention to address the gaps in the literature and in practice. This work will involve two stages. The first will be collaborative working with surgical patients and other stakeholders, including clinicians, throughout the developmental process, with reference to the behaviour change wheel and using co-design methodology. Stage 2 will involve a feasibility study and optimisation of the intervention in 2 NHS surgical centres, and these are South Tees and York. We know from the literature that uptake of interventions is often affected by failure to effectively promote them by healthcare professionals, and engagement can be affected by intervention content that doesn't appeal to patients or isn't relevant to their individual needs. Therefore, the first thing we plan to do is conduct a behavioural analysis to identify the behavioural determinants of promoting uptake and supporting delivery of the digital programme, and uptake and engagement by patients. And the outcome of this first analysis exercise will inform individual interviews with healthcare professionals and patients to facilitate an in-depth exploration of training and support requirements. We will also identify specific behavioural domains to guide intervention development decisions. For example, it will help us to identify whether skills-based training is mostly what's required to help facilitate promotion of these programs in routine clinical care. The next phase of the work will involve co-design workshops. And again, we know from the evidence that integrating stakeholder involvement in the development of interventions can increase uptake, promote engagement, and maximise acceptability and increase effectiveness in the long term. Therefore, we will conduct a series of co-design workshops involving patients, healthcare professionals, and this will facilitate collaborative decisions about intervention, form and content to ensure that it's what patients and healthcare professionals want and need. The endpoint of this process will be a digital multi-behavioural intervention ready for feasibility testing. So the evaluation framework that we aim to use is as follows. Our primary outcomes are acceptability and feasibility by patients and healthcare professionals, and we also aim to assess fidelity of delivery, receipt and enactment to ensure that the intervention can be delivered as intended, received by patients, and that the knowledge and skills that they acquire throughout the programme enables them to make behavioural changes. And those will be assessed by the list of secondary outcomes that we have here at the baseline prior to surgery and 3 months post-surgery. So in summary, we will develop and evaluate multi-behavioural digital intervention to support patients to make important changes to a number of risk behaviours prior to surgery. Theory-informed intervention development process using co-design methods aims to maximise uptake, engagement, feasibility and acceptability of the intervention. Should the intervention prove to be acceptable, hopefully this process will facilitate long-term effectiveness. I'd like to take this opportunity to acknowledge our funders, who are Macmillan Cancer Support and Sport England.
Thank you, Leah. You seem to have been cut off slightly in your prime there, just towards the end of the talk, so apologies for that. So just to keep going, we're now going to move on to, I'm sorry, it's slightly rapid pace here for delegates, so hopefully everybody's comfortable. Oh, next we're going to move to 2 presentations from Newcastle. And the first talk is called ChemoFit, Get Fitter Before Your Surgery. And the speaker is going to be Dr. Rona Sinclair. Rona is a research active consultant anaesthetist at the RVI in Newcastle. Her latest MD student and the team have been investigating exercise interventions in esophagogastric cancer patients during chemotherapy. So over to you. Thanks, Rona.
Good morning, my name is Rona Sinclair. I'm an anaesthetic consultant in Newcastle. Thank you very much for the opportunity to speak today and tell you a little bit about some of the research that we've been doing. So this is our ChemoFit study. It's a feasibility study looking at maintaining fitness during neoadjuvant chemotherapy during esophagogastric cancer treatment. And it's a study that we've been running for a few years. It has been fully funded with 2 competitive grants and submitted as part of an MD thesis. ChemoFit is based on the hypothesis that we believe that patients who are sedentary during chemotherapy lose background fitness, and that we believe we should be in an exercise program in order to increase their activity levels and improve their fitness before major surgery. So the hypothesis we tested with a feasibility study was will patients participate in a home-based exercise program during their chemotherapy before treatment for esophagogastric cancer. The primary outcomes of feasibility outcomes looking at recruitment rate, completion rate, compliance and engagement. So ChemoFit was implemented during the esophagogastric cancer pathway. This pathway starts off when patients present to a tertiary referral centre for staging of their tumour. At this point in time, they have a baseline exercise test and are discussed at the multidisciplinary team meeting. Thereafter, approximately 70% of patients receive preoperative chemotherapy, lasting approximately 3 months in the window leading up to their major surgical resection of their tumour at the end of this. We implemented an exercise intervention during this time, which was based at home, and asked the patients to increase their daily step count by 2,000 steps every day of the week. This could be achieved by walking, jogging, and was targeting a moderate walk scale intensity. They also did strengthening exercises each day, and the whole thing was orchestrated by the research registrar, who had a weekly telephone contact with our patients, giving them motivational advice, recording their results, and setting targets I'll go straight to the feasibility outcomes. So we screened all patients coming through the unit and had a recruitment rate of 72%. The main reasons for patients not being involved in this was the requirement to be present to sign consent and the number of patients that come from a long distance in our wide geographical area. Once patients had been recruited into the study, the completion rate was excellent at 92%. I'm sure you will understand that some patients become palliative during their cancer treatment, and therefore there were 2 patients that dropped out. The length of the programme lasted approximately 91 days. Patients were very good at wearing and using their pedometers and at recording step count data in diaries. And engagement with our telephone consultation was 100%. Patients really enjoyed this phone contact. Qualitative research was very interesting. This was undertaken online with focus groups and some semi-structured interviews. This was a change from the original protocol due to coronavirus forcing us online. 22 patients were interviewed and said that the programme was acceptable and tailored to their needs and circumstances. They reported that participation distracted them from their illness and treatment options, and that it was good to have something to focus on that provided. Furthermore, they highlighted the important parts of our programme, which were, could we measure the secondary outcomes successfully? These were put in there in order to design a larger study and to see that we could measure fitness and outcome measures. The answer was yes. Step counts, sarcopenia using CT and grip strength, exercise testing parameters, quality of life. So what does it mean for prehabilitation? Well, the feasibility study shows that it's possible to implement this type of regime. Overwhelmingly, the patients were highly motivated and compliant, and the unpowered secondary outcomes suggest that there's preservation of fitness and an improvement of quality of life while patients undergo the programme. Importantly, the pragmatic design that we put in place has made it easy to implement this type of programme, and hopefully will mean that it can be put into clinical practice in due course. This was one of the main targets in setting this up as a home-based exercise programme that did not require large amounts of kit and just required simple supervision once a patient was motivated. I think if you asked the researchers, the patients, people will be interested in the exercise testing fitness data. So I have put it in despite not being powered to show this. So this compares our current ChemoFit regime on the sideline versus our previous study that was published in 2018, which looked at various time points during chemotherapy and reported their anaerobic threshold and peak oxygen uptake. These are shown in the dotted lines. Previously, we have shown a marked, significant and sustained reduction in fitness, which on the face of it looks as though it has been prevented with the use of the. So lastly, what does it mean for patients? Well, esophageal disease is major surgery, and this benefits our high-risk patients. It makes a simple programme that can help them. The engagement was excellent, the qualitative data was excellent, and I think the real question that remains is how do we get our trust to support this in the future so that it can benefit further patients. Thank you for listening.
Yes, Rona poses an important question at the end there, which is how can we take these exciting innovations to the next level? So we'll have plenty of opportunity, I'm sure, to discuss that during the Q&A sessions. So next, I'm going to move on to the next presentation from Newcastle, from the Newcastle team, which is going to be done by Mackenzie Fong. The talk is, are behaviour change interventions before surgery acceptable and effective? Mackenzie originally trained as a dietitian and has worked in health research for around 10 years and is currently a research fellow in prevention, early intervention and behaviour change at the National Institute for Health Research Applied Research Collaboration in the northeast of North Cumbria. Mackenzie's main interests are evaluating interventions and policies for obesity prevention and management. So over to you, please, Mackenzie. Thank you.
Hello, my name is Mackenzie Fong, and today I'll be discussing behaviour change interventions before surgery. Are they acceptable and are they effective? I'm going to start off with a bit of background information that you'll probably already be familiar with. So as we know, those traditional prehab interventions aim to optimise patients' functional capacity before surgery to improve post-op outcomes. So they'll typically involve acute medicalised interventions in higher risk groups. Protocols will of course vary case by case, but prehab may include one or more of supervised exercise training, nutrition support like supplementation, and medical optimization. So for example, smoking and alcohol cessation and medication adjustment. However, a recent report by the College of Anaesthetists highlights the potential for prehabilitation to go further and promote sustained health behaviour change. So health behaviour is a really broad term, but for this presentation and for our work more broadly, we're focusing on the big four modifiable health risk behaviours, which are, of course, smoking, alcohol use, poor diet, and low physical activity. So what is the case for providing behaviour change support before surgery? Well, firstly, those big four health risk behaviours are strongly linked to the risk of non-communicable diseases, or NCDs, so namely cardiovascular diseases, cancers, type 2 diabetes, and chronic respiratory diseases. In England, these NCDs are leading causes of disability and premature mortality. Improving health behaviours on a population level and the means to address NCDs remains a significant challenge and requires a whole systems approach. So of course we need those universal primary prevention measures, for example, taxation of alcohol and tobacco products, but we also need targeted secondary and tertiary prevention measures for people with higher risk profiles and for those who already have NCDs and need management and treatment. So pre-operative provision of more intensive interventions to support health behaviour change can form an important part of that system-wide strategy to manage non-communicable disease. Also, surgery is considered to be a teachable moment, so people may be more likely to reflect on their health behaviours and may feel more motivated and confident to change their behaviour. This approach also holds the potential to reach a lot of people and also to reach those who are most in need. So lots of people with NCDs will require surgery. So for example, in the UK, 45% of people with cancer will have surgery. Regarding cardiovascular disease, around 15,000 people will undergo a coronary bypass procedure each year, and angioplasty with stent is in the top 10 most common procedures. Also, people with greater socioeconomic deprivation are more likely to have multiple poor health behaviours, and NCDs are more prevalent in this group. So by offering behaviour change support via surgical pathways, we can target those people who are most in need and help to address health inequalities. And lastly, COVID-19 has contributed to longer waiting lists for surgery, and there's a call amongst anaesthetists to turn waiting lists into preparation lists. So research into preoperative health and behaviour change interventions are really timely and topical. So we've designed a program of work to investigate health behaviour change interventions in surgical populations, and this leads me onto our first piece of work, which asks, are these interventions feasible and acceptable? And to find out the answer to this, we're conducting a pilot feasibility study called the TechStat study. So we're currently in the process of recruiting 60 patients with peripheral arterial disease who attend local vascular clinics and who have high deprivation scores. So eligible and consenting patients are being randomised on a 1-to-1 ratio to either receive 12 weeks of standard care or a 12-week telehealth behaviour change intervention. So the intervention is being delivered by HealthWorks, which is a Newcastle-based charity. Patients in the intervention group will meet with their dedicated health trainer once a week, and they'll discuss their physical activity, dietary intake, smoking and alcohol habits, and also sleep and stress management. Twice a week, they'll also take part in a supervised exercise session by Zoom, and they'll also receive a Fitbit device to monitor their activity. Those that need it will also be provided with a tablet device and mobile internet as well. The standard care group also receive a Fitbit, but they're just advised to walk for 30 minutes 3 to 5 times a week as per NICE guidelines. In terms of outcomes, feasibility is going to be determined through rates of recruitment, retention, attendance, and completion of the assessment measures. We're going to explore acceptability through interviews and focus groups with patients from both arms of the study and also the health trainers. We're going to explore preliminary effectiveness through the 6-minute walk test, quality of life assessments, step count, dietary quality, alcohol use, etc. So patients will complete these measures at baseline and also 12-week follow-up. And we're also going to be developing a trialling tools for a health economic evaluation. So we're going to use all these feasibility and acceptability data and use that to determine if we can progress to a definitive trial in the future. To complement this work, we are also conducting a complete systematic review to understand the current evidence base around the effectiveness of these interventions. So our review question is, what is the current evidence of effectiveness of perioperative health behaviour change interventions in adults for improving health behaviours, outcomes and inequalities? So we are including studies that involve adults who require surgery. We're interested in interventions that are initiated before surgery and that promote sustained behaviour change. We are comparing these interventions to usual care, no intervention, for example, a waitlist control, or an intervention that doesn't aim to modify health behaviours. And our outcomes and interests are broad. They include health behaviours, for example, physical activity levels, dietary intake, smoking status, but also health and wellbeing outcomes. In terms of the study designs, we're interested in including, we are looking at individual and cluster RCTs, non-randomized controlled trials, and controlled before and after studies. So we've conducted the searches. We did that in 5 databases and also grey literature. This yielded close to 30,000 results, 6,000 of which are duplicates. We've been independently screening those for eligibility, and we've almost finished double screening the articles. So I can share with you some initial kind of general impressions. Firstly, the evidence base is very sparse. Most studies have examined those traditional kind of acute medicalised prehabilitation programs, and very few appear to promote sustained health behaviour change. Secondly, very few appear to report results by socioeconomic group. As for our planned analysis, we plan to report findings in a narrative synthesis. We don't anticipate that there's going to be a kind of a standardised metric that we can use to kind of pull all the findings together. So we plan to summarise effect estimates in text and tables. We're going to assess the risk of bias using Cochrane methodology, and we're going to assess the certainty of the evidence using the GRADE framework. And if feasible, we may conduct an equity to have this piece of work complete in the next few months. That brings me to the end of this presentation. I'd like to acknowledge the TextPad and Systematic Review team, and in particular Dr. James Apprentice, Ms. Maisie Rowland, and Professor Eileen Kaner, who are real driving forces behind this work. So thank you very much for your interest and for your attention.
Thank you very much, Mackenzie. A very interesting work. That's really exciting for your team to be moving forwards with. So congratulations. Look forward to hearing about the outcomes of that as you move on. Okay, so the final talk of the session is going to be moving to Durham next. So we'll move around the region a bit. But the next presentation is going to be done by Professor Edward Kanonga. And the talk is The Wellbeing for the Time Being Durham Programme, Emerging Model and Early Insights. Edward is a passionate public health leader. He's currently working as Director for Population Health Management at North East Commissioning Support and a Public Health Consultant at County Durham and Darlington Foundation Trust, and also CHUV. Forgive me, I can't exactly remember the acronym stands for. T's Esquire Valley, I think. He previously worked as a Joint Director of Public Health in Middlesbrough, Redcar and Cleveland Councils. And in that time, Edward and I actually got to know each other pretty well. So over to you, Edward, and looking forward to what you have to say.
Hi, colleagues. My name is Edward Kodonga. I'm a public health consultant in CDDFT and CHUV, but I also work as a program director for population health management for NEX, which is our commissioning support organization. I'm here to talk to you about well-being for the time being, which is a program we are launching in Durham, which is informed by prehabilitation principles, embedding public health approaches for targeted support, and also supported by robust clinical pathways to make sure that what we are offering patients is safe, it is effective, and it is in line with the treatment pathways. So I'm just going to share with you a presentation that I did for a recent conference last week on the program. So well-being for the time being, supporting surgical and cancer patients in Durham. Apologies for the size of the font, but we'll make sure that this is available to you after the program. So I'm going to cover background and context, an outline of the service description, the pathways that we are proposing, the levels of support, and then I'll finish off with a few concluding remarks. So the well-being for the time being program is an integrated patient-focused service to support patients who are currently waiting for surgery, as well as those patients who have had a recent diagnosis for cancer and are about to commence their treatments. The program is heavily informed by the compelling evidence based on the benefits of prehabilitation for pre-surgical patients, the work that is being done, and colleagues can speak to this more eloquently than I can, on perioperative medicine, but also the prehabilitation agenda for cancer patients. We have been fortunate that we accessed just shy of £1 million from Durham County Council funding on a non-recurrent basis to develop a program that will support the Waiting Well initiative. This program will be a community-based program designed to improve the health and well-being and pre-surgical or pre-treatment fitness for patients awaiting surgery or about to commence their cancer treatments. The service is part of a broader offer. So in Durham, we've got a model called the Well-being for the Time Being, which is a service that brings together an integrated offer to address some of those risk factors, so obesity, sleep interventions, emotional well-being. We also have social prescribers within that service. And so this will be the host for this service, which allows us then to address all the other issues that the patients might have whilst they're waiting for surgery. We're looking at 5 stages on that pathway, which starts off with the diagnostic workup, and then patients get listed for surgery or for treatments. And then there's the waiting time, which we are very keen to turn into preparation time rather than it being idle time. Then there's the phase when they receive their surgery, and then how do we align that with some of our rehabilitation pathways so that they can continue with their recovery. And then last but not least, we're hoping that for some patients that this could lead to sustainable and long-term changes in terms of some of those risk factors. We know that some of those things are not only good for your pre-operative stage, we also know that that is also good for you post-operatively and for the rest of your life. So we are hoping that this, as I know colleagues describe these as teachable moments, result in learning that is applied for the rest of people's lives. So the framework that we are working to has got 4 levels, which is about understanding that every patient is different. They come at this from different points of view, with different needs, and with different vulnerabilities. So the universal offer is looking at how best do we get the information across to all the patients, so that those who can will heed the advice and self-care. And included within that will be signposting people to a wide range of resources. Then the level 1 is more beginning to get a bit more personalized approaches. And this is about identifying those patients who will need that additional support through a telephone contact, brief advice, brief intervention, motivational support. And for some patients, that will be enough, and they can go on and implement the advice. And then the next level is a bit more intense. This is an 8-week program, which is accessed as an in-person group attendance, or alternatively as a virtual offer, where patients can then participate in the program alongside other patients, and that can help create that peer support, but also enables them to continue with the program. These programs will be run by trained advanced well-being practitioners, as we are calling them, and they will have training in the delivery of the major components of prehabilitation. But it will all be overseen by a clinical group. We've also got in our model allied health professionals, so we've got funding for a physio, we've got funding for speech and language therapists, we've got funding for a dietitian, and also we will get occupational therapy support in the program. Then level 3 will be much more personalized. So this is individual one-to-one support based on a personalized plan that reflects the individual's needs and making sure that they receive appropriate support. And throughout that offer, all those 4 levels, we're taking an approach of proportionate universalism. So this is something that was coined by Sir Michael Marmot, which is about the level of support should be proportionate to the level of need. And so those who will receive the level 3 are most likely to be those who we know that anything lower than that might not result in engagement. So you're talking of people with special needs, so people with learning disabilities, people living with serious mental illness, and other patients who might have a wide range of challenging and complex arrangements. We're hoping to use the data to inform this, so a population health management approach. We've already run a proof of concept where we've linked primary care data with the secondary care patient waiting list, and that suddenly increases our understanding. There's a group, and I won't steal the thunder because I know it's a presentation that's going to be made here, that has been looking at what are the key considerations in terms of prioritization, both prioritization for surgery, but also identifying who is least likely to engage with such programs and how best and what is the level of support and offer we could give them. So that's the well-being for the time being. Hopefully that gives you an overview of what the proposed model will look like. We are in the final stages of recruitment, and we are hoping very soon to be beginning to roll out this program. And in future, we'll be more than happy to come back and report on the outcomes. So in conclusion, we know that COVID-19 has affected health delivery in many different ways, both directly and indirectly. And the indirect impact, there is lots of emerging evidence on how that is impacting on people's health and well-being, ranging from changes in risk, lifestyle risk factors, more to do with limited physical activity during the lockdown periods, changes in nutrition habits, changes in alcohol use and smoking status, all of those will have an impact, especially for those patients who are waiting for surgery. Management of long-term conditions would have been disrupted, and so there is a lot of people who need medical optimization to make sure that when their turn comes, they are as fit as possible. And we also know that surgical treatments have been affected, and almost every trust will have a backlog of surgical patients waiting. So all of these factors, for me, I feel they highlight the importance of rehabilitation approaches and how best we can, in a coordinated way, support patients to turn their waiting time into preparation time. So thank you very much, and hopefully that gives you a synopsis of the work we are planning to do in Durham, and I'll be happy to take questions in the Q&A session. Thank you.
So thank you very much to Edward for that impressive piece of work that's about to be launched in the Durham area. I'm sure lots of us will be jealous of the funding that Edward's achieved to do that. That's great work. So amazingly, looking at my watch, it's 10:15 and the program says Q&A at 10:15. So despite a few glitches, we're running the time, which is brilliant. And thank you for all of the speakers for a series of engaging talks, very interesting work going on. So I'd like to open the floor now to any questions. Remember, you can post your question in the chat box, or you can put your hand up and ask it live, and somebody will bring it to my attention for anybody who's got their hand up. So hi everybody, we're just about ready to start. It's a bit of a whirlwind, I'm afraid, and thanks for your patience with that, but hopefully you'll find this next session rewarding. So hopefully everybody's back, but we need to keep to time, so I'm going to start. So the next session is patient experiences and preferences. And to start with, what I'd like to do is we're delighted to have two people who have previously undergone surgery at different time points in the recent and less than recent past. And that is called Then and Now. And we're basically going to explore the experiences of people who have been through maybe an older style NHS system and surgery more recently. So our first representative is Dave Apprentice. Dave was born and grew up in Leeds.
Hey, what you doing?
Sorry, somebody popping in there. He was General Secretary of Unison, the public service union, for over 20 years until his retirement in January this year. Dave had major surgery. He had removal of his esophagus or gullet and stomach in 2000, so over 20 years ago, and that was followed up by 6 sessions of chemotherapy and also complications when he got MRSA. There's more about Dave's biography on the website, so anybody wanting more information, please have a look there. He's also the father of one of our organising committee, James. Our other patient representative is Sue Hackett. Sue tells me that she's 53 and married with 2 sons who are 24 and 14. Sue has been a nurse in the NHS for over 30 years with extensive experience in cardiology, but has been working in primary care and more recently as an advanced nurse practitioner in palliative care through hospice work. Sue tells us that she's a poorly controlled diabetic, a hypertensive, and poor lifestyle choices led to her having problem with a blocked main blood vessel, her aorta, requiring major bypass surgery in October 2000. So both of our representatives have pretty much had as major surgery as you can undergo. So welcome both. If you could unmute yourself, that would be great. So to start with, maybe I'll start with you, Dave.
Okay.
When welcome to start with. We've got about 90 people online who are going to be interested in what you guys have got to say. How did you feel physically and emotionally when you found out your diagnosis and that you were going to need major surgery?
Okay, it's great to be with you all today. When I found out that I had very mature cancer, it was devastating. I'd just become General Secretary of the Public Service Union, the biggest trade union in the country. I had to take down all of the cards congratulating me and then put cards up wishing me well in my illness. But it was the way that I was told, which may have some relevance to today, because it was done very quickly. I was very ill. Initially, it was thought to be maybe stomach ulcers or a hiatus hernia, but the cancer had gone to a very mature stage during that period. And eventually I did have a barium meal. The radiographer cried when she saw the extent of the problem. And within a few days, I was having a scan and endoscopy. The endoscopy was with the surgeon. And what I want to say, at the very, very beginning, the NHS saved my life, like millions of other people. They're tremendous, but it's a pressure cooker. And I had the endoscopy. I did say that I wanted to know what the outcome was that day. I didn't want to go away. So the surgeon, at the end of a very long day, came to the general ward where I was recovering from the anaesthesia and simply said, well, you are into palliative care. You need to go home and put your house in order. And again, it's not like now where if you do have anaesthetics, somebody comes with you. I had to get dressed and leave and then try and work it all out in my mind. So it was absolutely devastating. And then we had to move from there, eventually through chemotherapy, which was another hospital, which was brilliant. It was, met so many kind people. They actually gave you a menu for the food rather than just giving you the food that everybody gets, which is inedible. And you felt like a human being. And they did a tremendous amount for my self-respect and will to go forward. Eventually the surgeon, who was very close to him now, eventually the surgeon said, if you do chemotherapy, you shrink the cancer, which I believe was 12 centimetres, then we'll consider the operation, which entailed cutting out the stomach, turning me over, then opening up my rib cage.
I'm going to stop you just there, Dave. That's fascinating and obviously quite powerful early story about how you felt at that point. Sue, would you like to come in now and kind of tell us about how you felt at the time when you presumably saw vascular surgeons and this concept of shared decision making, which seems to be cynically the surgeon sharing their decision with you. Tell us about how you felt, please, Sue.
Hi, and I'd just like to say as well, thank you for inviting me along today. So yeah, I think before I saw the vascular surgeon, I had a good inkling of what was going on with me, maybe about 6 months prior to that. So physically, I hadn't looked after myself very well at all. And I didn't look after my diabetes. That was out of control. I was getting pain on walking. My exercise tolerance had reduced to about 50 to 80 metres. So at that point, when I attended my GPs, I kind of had an idea what was going on. And that was a point that I really needed to make realised I needed to make quite big lifestyle changes. There was a period of waiting from that time to seeing the vascular team in the October of 2020. And it was at that point that I really realised that I was going to need major surgery. Was devastated, really. I think I knew what the implications of the disease meant on my life and my future, that it wasn't just the surgery I was having. It was the fact that if my main aorta was blocked as much as it was, what was going on elsewhere. So physically, I was really quite sedentary. I was restricted because of my exercise tolerance. And emotionally, I was past myself, really. I was frightened for what it meant for my future, frightened for the surgery and what I was going to face there. I think I was embarrassed and ashamed because I knew that it was my lifestyle that had led to the place that I was in at that point. So it was a lot to deal with. And there was a long period of time before really I got to speak to anybody about it. Yeah.
Okay, so that's brilliant. Thanks for sharing that. So I guess moving on from that, you'll be aware that the theme of the day is how we can prepare people for surgery to support these difficulties that people face at this challenging time. And you've touched, Sue, on the impact of lifestyle choices, and Dave's mentioned that he had to have chemotherapy, which has a major impact on you. Would either of you like to describe if you were aware about any support you could access to improve your health and well-being before surgery?
Very quickly.
Yeah, go ahead.
Okay, very quickly, no, I was not advised of any support that I could get. As I said before, it was a pressure cooker at the time, and and everybody on the medical side especially were they were running just to stand still. They were doing a fantastic job as far as the operation is concerned, but I was not advised of anything that I could do to improve my chances of getting through the operation. I had been told, and I had to sign a form to say I recognised it, that I've been told that 20% of people who have this operation die on the operating table. That just came out of the blue. And again, I was by myself when that type of thing was said. But the support, I think it may have been because the chemotherapy was at a different hospital. So the surgeon stood back until there'd been 3 lots of chemotherapy before he would say that he would operate. It depended on shrinking the tumour itself. So during that period, I supported myself. Mention's already been made about walking. What I would do is I would walk as far as I could away from the house, knowing that I couldn't get back, that I couldn't walk any further. And then I'd turn round and I'd make myself get back. So there are various things. After the second session of chemotherapy, I just went into the cafe in the hospital, got a ham sandwich, and it was edible. I could eat it the first time in months, but it was me just checking it out. And again, on the well-being side, my weight did drop from 12 stone to 8. And I did get the impression that I may not be viable, but there's very, very little help on the dietitian side. So
do you kind of presumably feel you would have benefited if something had been available for you at that stage? Yes,
I was doing it myself. People need information. It's issue of information. If you don't get it from the hospital, from the NHS, you go looking for it. And even then, 21 years ago, the internet was awash with horror stories. But I think people need information, but they also need well-being.
So Sue, obviously you've had surgery in the more recent past. Were you aware about how you could prepare yourself in the lead up to surgery?
So I think my background gave me an awareness of where I could look for information. But I think my expectations weren't really met. I had breast cancer 8 years ago, and I felt that the support I got there through the breast team, they really talked me through it all. And I think in this situation, I was given this diagnosis. I was told it was major surgery, and then basically left to it until the period of getting my diagnosis in the October and actually finding out about the PrepWell programme in the February. There was 4 months there really that I was just left to research it myself. And I'm one of these people, I want to know everything, every possible scenario. So I Googled. Fortunately, I knew what I was looking for, so I wasn't misled down some sort of social media routes and things. But I would say that, so yes, I was able to research for myself expectations of the surgery, the anaesthetic recovery, but I wasn't directed to do that until the February. So that's probably about 8 months from my initial visit to the GP before I really felt the support kick in.
And obviously then, how were you introduced to PrepWell, and what were your, briefly just describe the kind of benefits or non-benefits for how you felt?
So, as I said, I'm an ostrich. I'd buried my head in the sand. I had neglected my own health for years. So I wasn't in a good place emotionally with it all. You know, when I had the breast cancer, I was a lot more pragmatic and resilient. And this, perhaps because I didn't feel as if I'd had control over that, whereas this was a situation that I'd felt was self-induced. So it took me to a different place psychologically. And physically, when I'd attended my GP in the March, April time, and realised at that point that this was peripheral vascular disease, and I was really frightened then for what that meant. And that was a really good driver to get me to make massive lifestyle changes. So
just tell us a little bit about, you know, what you experienced with the prehab service, and did that help you? What support? Just briefly, because we're kind of got 5 minutes left. There's a couple of other things I want to.
So for definite, for me, Rhiannon mentioned it at my pre-assessment visit. It was the first I knew about it, and I was just really keen to jump on board. I knew that to get through this and give myself the best possible chance of recovery, that they'd initially told me was 3 to 6 months, that I just needed to jump on board. And I was then directed by Esther to the websites and joined the online classes, found it invaluable, really.
And so I'm hearing kind of from both of you that there was quite a lot of almost stagnant time between, well, perhaps not so much for Dave, he's talking about the pressure cooker environment, but Dave, do you think that there would be some merit in one of the talks by Chris Snowden has talked about, you know, really making this work in a much more seamless fashion, so primary care and work in the secondary care? How do you feel, Dave, about GPs perhaps being more active in this process, or do you think they are? Just tell us if you have any thoughts about if that would be beneficial.
Yeah, the GP was great in getting things moving very, very quickly. So I'll ever be thankful to him. But then they pulled back. You're in the hospital environment, and you only really see the GP if you need to change medication. So they're not involved in taking forward the patient and making sure it's a good outcome. It's not just the NHS. There's massive debates going on at the moment about care. It's this dichotomy between the NHS, local government services, and whether or not they can be put together as a holistic way of treating the patient. I've listened to some of the contributions this morning. Dignity is really important. You know, you're at your lowest ebb, but you want to be treated with dignity in going through that. We talk about, you know, diet, and we talk about physical fitness, but mental well-being is also vital if you're going to get through these types of operations. And as I said before, you need signposting to resources. So all the work that I heard this morning, I didn't get any of that, but it's great and I wish I had. But it's got to be universal. It can't be just because a consultant thinks, I think this is the right thing to do, therefore we'll do it here. There's got to be something within the NHS where it's guidance to all hospitals where we're talking about major surgery.
The quality of access, I think that's a powerful thing, isn't it?
Yeah.
I think...
sorry.
sorry, just to add, to interject from a primary care point of view, I would have liked Prepwell to have been introduced to me on the day that the decision was made that I needed surgery and not 4 months later. I think in general practice, general practitioners would not even have been aware of a prehabilitation course. And I think there's so many time restraints. And so I think, but yeah, I could have been directed to some appropriate websites at least for my first interaction with the GP. But I would have liked Prepwell to have been introduced.
So
4 months was.
Yeah, no, I can, and I'll have to blame Esther for that.
Can I just make a quick point?
Yes, of course.
People's circumstances are different. I had the chemotherapy overnight and I had a bottle attached to me for 6 months of cisplatin going straight in through a Hickman line into my heart. But I was able to talk to and be with people who weren't as fortunate as me. I get the public service sick pay scheme, 6 months on full pay, 6 months half pay. So many people going through what I was going through. They'd had their jobs taken away from them. They didn't have a home to go back to. They couldn't climb the stairs back to that home. They had nobody to look after them once they were there, but nothing could be provided because the resources weren't there. And these projects rectify something that we were aware of over 20 years ago.
No, that's great. And so I guess we're kind of in the last minute. Do either of you have a kind of final message that you would like to say, you know, just in 30 seconds? Do you think there's anything that the NHS should be offering or could do better in this respect, for example?
Sue, do you want to go?
I just think, to me, the benefits of the prehabilitation were amazing. And I felt that my recovery was significantly reduced because of it. In the hospital, getting around the bed, I think the physical courses helps with the psychological issues as well. And as I said, I just think we should have been signposted. I personally would have liked my GP to have signposted me sooner. Sorry, I'll let you say it.
And Dave, any final thoughts?
My only final thought is on what you're doing. It's long overdue. It's got to be universal. And I do know from what I did for myself how important it is to get your body into a state where it can go through major surgery. You know, my rib cage had to be broken, my stomach removed. You can't go into that if you're on death's door.
And I think that's kind of the powerful thing about you wouldn't run a marathon before, you know, training and preparing yourself. So, we have to draw it to a close there. I can see, you know, how emotive this has been for both of you actually. And we're so pleased that you've been able to share those experiences. And I'm positive that there's going to be some interest from the delegates to ask questions. So if you can join us for that final half hour or from 11:25, that would be great. So thank you very much. We're going to move now on to, so if you could just mute your microphones, please. That's what I was trying to say.
Thank you.
But thank you. So moving on to kind of develop this theme a little bit more, we're going to have a talk from Dr. James Durand, who has been doing some research at South Tees and other centres looking at exploring patient preferences for home-based prehabilitation. I'm just flicking through the many windows I've got open on my computer. James and I have been working together for many years now, nearly 10, I think. He's a trainee in anaesthesia and intensive care medicine and is studying for a PhD focused on remotely supervised prehabilitation prior to major surgery, which he's doing at Northumbria University. So I'm going to pass the floor over to James. Thank you.
Hello everyone, my name's James and thank you very much to the organising team for the opportunity to share some of the work we've been doing around patient preferences for home-based prehab using conjoint analysis. I'll split this talk into 3 parts. Conjoint analysis is brand new to me, and I suspect maybe to others. So I'll begin with an overview. I'll then introduce the Improving Health at Home Before Surgery study, where we utilise it to explore patient preferences for remotely supervised or home-based prehab options, followed by some initial results from the study. Conjoint analysis was initially developed and is most widely used still as a commercial tool. And the most helpful introduction for me was thinking about trying to buy a car. How likely you are to purchase a product like this relates to its component attributes, and we naturally consider these as a package in combination. How far and in what way each influences our overall decision-making is individual, and it's normal for us to make trade-offs between those attributes that are more or less important to us. Exploring this would, I think, naturally lend itself to a qualitative method, and I think conjoint analysis is at its heart, but it seeks to add a degree of quantification to this complex interplay between attributes that influences our decision-making. Prehabilitation interventions are generally complex healthcare interventions with numerous component attributes and options for their delivery. Conjoint analysis has been increasingly applied in a healthcare setting to inform the design and delivery of interventions like this, in order to help us build things that are most likely to effectively support patient engagement. These studies are also known as discrete choice experiments and are structured around the predefined attributes of an intervention and the levels or options for delivering them. This is an example set that could be fed into a DC about cars, for example. Several methods exist, but all involve presenting participants with concepts built from the specified attributes and levels. Each comparison is known as a choice set. Participants are asked to choose a preferred option each time, and by completing enough of these in series and varying the concepts in a structured way, we gather information about which attributes are more important and which levels are most acceptable. There are two main outputs from DCE: attribute relative importance in choice making and the utility scores reflecting the acceptability of each level. Relative importance is scored from 0 to 100%. An attribute scoring 100% would have dominated choices completely, and equally 0% implies that it was essentially completely ignored. Typically, each attribute will fall somewhere in between, with scores collectively adding up to 100% for all attributes. The absolute values are less important than how those scores relate to one another. Attribute relative importance is dictated by the range in utility scores of its component levels. Within each attribute, level utility scores reflect acceptability to respondents. They can be positive or negative, indicating more or less acceptability. Level utilities can be compared to others within the same attribute only, and must be considered in the context of that attribute's relative importance. So how have we applied this to patients preparing for surgery? We designed an electronic questionnaire incorporating a form of conjoint analysis called adaptive choice-based conjoint. The questionnaire focused on patient preferences for how multimodal, remotely supervised rehab support might be delivered. The study ran at 10 NHS sites, recruiting patients preparing for major surgical intervention. Patients were able to participate face-to-face in clinic or remotely using WebLink. ACBC proceeds in 3 stages, each feeding information to the next, allowing the subsequent choice sets and concepts shown to adapt based on those responses, which hopes to efficiently gather information on as many attributes and levels as possible. In the opening build your own phase, participants indicate their preferred level for each attribute, which provides the questionnaire with an ideal concept or ideal scenario or ideal prehab package. This is used as the basis for the screening stage, where they are shown 4 concepts on screen that all vary slightly from their ideal. They're asked to assess each of those in turn and say whether that would be a still potentially acceptable option for them or an absolute no-go. This stage aims to essentially detect levels that are either must-have or totally unacceptable for that part. These results then feed into a more classic conjoint analysis choice tournament. Participants are shown screens with 3 concepts on at a time and asked to pick a winner. These are the attributes and levels this DCE was built from. Format: should the package be delivered in a paper-based or digital way? Start point: are respondents more interested in getting maximum possible productive time to utilise the support or to ensure an operation is actually going ahead first before they start? Start place: where should their initial needs assessment and introduction to the programme happen? Should a wearable device be integrated to monitor progress? Should the package stand alone as a pure home-based intervention, or signpost and try and integrate with other local available potentially face-to-face services? And finally, HCP check-in: how often should a review of progress happen with a supervised professional when using the package? This slide summarises the progress of participants through the study, and from 422 patients initially approached, we obtained 164 complete responses. So a response rate of 40% and a completion rate of 94.8%. This is an abridged summary of our cohort characteristics, showing an expected mean age and gender split, with a good spread of surgical specialties represented. So the results for the whole cohort, starting with attribute relative importances. I've opted to include 95% confidence intervals here for the mean importance estimates. And from this, we can see that the 4 attributes on the right of the screen have separated themselves from the other 2, but we can't confidently take them apart any further, reflecting the variation in responses we observed from individuals across the cohort. Looking at the level utilities, with the blue lines here grouping those levels from the same attribute together to help us compare. Start point was the least important attribute overall, with neither level obviously favoured by the cohort. There was a preference for a paper-based format. However, the wide confidence intervals here show that there was a substantial variance across the cohort on this attribute, and that these 2 levels were very polarising. The cohort settled on a programme that could be initiated at home, ideally with a fortnightly HCP review, and with an integration of a wearable device. And finally, they seem to prefer a programme that could be undertaken exclusively in and around their home. An advantage of DCE is it allows us to seek out subgroups within the respondents, showing a similar pattern of attribute importance and level preferences, and then to characterise them. A good example of this is trying to explore this apparent paper-digital divide in a little bit more detail. So we separated participants who had initially opted for paper and digital at the build your own stage, which actually split the cohort almost down the middle, and then looked at their groups' individual and level results. So for the paper-based group, programme format separated itself clearly from the other attributes as the most important in influencing their decision. The reason for that is evident in the level utility scores, which showed a very clear preference for paper over digital. The pattern otherwise followed the cohort overall, but they were pretty indifferent to wearable integration. So did we see the opposite in the digital group? Well, whilst programme format remained an important attribute, it didn't hold quite the same dominance over the others for this group in guiding choices. There was a clear preference for digital over paper, but not to the same degree as we saw in the paper-based group. And in addition, we saw a clear preference here for the use of wearable devices within the package. So I'm hoping this has offered an overview of what contract analysis can do for us. It is a potentially powerful tool in supporting intervention design and delivery. And so far it seems that even in the relatively narrow context of home-based rehab options, we still need a menu of offers in order to effectively engage and support the maximum range of patients. And within this population, we've already seen a clear appetite for both paper and digital intervention. So finally, I'd like to take the opportunity to thank my supervisory team and the study team who have helped me in the delivery of the study, and also to those recruiting sites and FPIs who have worked extremely hard and made my first experience in a CI role really quite enjoyable. So thank you all very much for listening.
Okay, and thank you, James, for that presentation. It took me about 2 goes to understand the content of it, so hopefully others have picked it up a bit sooner than I did. So finally, well, not quite finally, we're going to move into the next session, which is to do with, I guess, the health economic case, and does it kind of return on investment for all of this work? Because essentially it's all very well having all of these initiatives and innovations going on, but if we're going to be able to provide that support that both Dave and Sue have kind of said needs to be accessible to all patients in future, we need to make a kind of sustainable case. So the next session is System Efficiencies, Return on Investment, and we're going to have some fun and games next with our next speaker, Joe Gray, who is giving a talk about Does It Stack Up? So that's an interesting title for everybody. Joe is an experienced health economist with special interests in health economic evaluation of health and social care interventions and priority setting methods to help underpin commissioning processes. So Joe is had to be special, so she's doing her presentation live to us, and has just returned from a nice holiday in Greece, so she should be nice and fresh to do this. So over to you, Joe. Thank you.
Okay, so while Laura is putting those slides together, Obviously, health economics, I feel quite humbled after reading those powerful sort of, I suppose, histories of what patients themselves have experienced. But I guess whether or not we like it or not in the NHS, as we know, we've got a scarce resource. And what we need to do with those scarce resources is make sure that we implement services or interventions that maximise our health and well-being for the resources that we've got. In other words, another way to look at it might be that we want to have the biggest bang for the buck. And it's imperative, therefore, that we try and show some health economics as well as clinical outcomes, some health economics outcomes, so that we can actually try and persuade commissioners and providers to actually, sort of make these services as if they are cost effective and indeed effective, that they should be, sort of provided across the NHS and not just to specific areas, as we've already said. Now, in the context of COVID, this is even more imperative, as we've seen that demand is exceeding supply. And it's important that we look to interventions that do improve health and well-being, whilst giving us some efficiency savings in perhaps reductions in length of stay, freeing up hospital beds, freeing up resources, reducing readmissions. And so that's what I'm going to be talking to you about today. So next slide, please. So what I'm going to talk to really is a set of evaluation results regarding clinical and health economic outcomes that really I've been working on for the last probably, I suppose, 10 years or so, 8 years with the Prepwell team down on Teesside. And it really, it's a chronological order because Prepwell originally started off on vascular patients with high intensity training. And as you've seen, is subsequently been sort of expanded to include other medical specialities, including orthopedics. So I'm going to take you through a short piece for some key headline results, really, from small feasibility studies to larger comparative cohort studies that we've done, and then finally finish with what we have plans for further research. So I guess Prepwell started with high intensity training. It was a feasibility study for high intensity training for vascular surgery for aortic repair. And we published the findings from the feasibility trial according to this in 2017. And basically we had a usual care or a control group and patients who in an intervention group received high intensity training, exercise face-to-face, 3 exercise sessions per week for 4 weeks, and then weekly maintenance sessions if the surgery was delayed. Now these, I understand, are very small numbers. I'll talk about research about bigger numbers in a couple of minutes' time. So we had 27 patients in the exercise group, face-to-face, and 26 patients in the control group, which was usual care. If we can just go to the next slide, please. So the AAA hit results, as this study was known, were albeit small numbers, and as a feasibility study looked at just descriptive statistics. We found that the median duration in the exercise group following surgery was 7 days and was 6 days in the control group. Now, if we think about day case or costs of day case ranging from anything for an average of about £250 per case, but that ranges from, sort of quite excessive £600 to £800, excluding high dependency and intensive care wards. So that 1 day is quite substantial in terms of if that's sort of those savings across large numbers of patients. And indeed, those savings wouldn't be important if we hadn't seen necessarily an improvement in health-related quality of life. So in terms of outcomes, more importantly, when people exercise programs, you see there at week 5, we had a health-related quality life of about 86% in the intervention group and 79% in the control group. And following surgery, that improvement or that increase in quality of life for the exercise folks, actually it carried on over the control group. So you can see there at week 12, you've got 84% quality of life and 76% actually in the control group. So actually those people that were in the control group, actually they got worse after surgery up to week 12, as you might expect. If we can just, next slide please, I've always wanted to say that. We did a micro costing exercise of what it cost for the exercise programme as it was known then, pre-PrepWell days. And it cost on average about £1,176 per patient. So the cost of the exercise group there in the exercise column. Now, if we go down, we obviously the costs of the actual intervention itself, the surgical intervention is included. But interestingly, if we go down to post-discharge costs, what we can see is costs in the control group were quite a bit higher than those in the exercise group, and that was due to the number of readmissions. The exercise group didn't have any readmissions, albeit small numbers, control group did. So we get an average total cost difference of about £510 per patient. Now that figure actually is highly dependent on, that's overall, was highly dependent on waiting time. So the longer the waiting time, the more expensive, I suppose, the intervention was, because they got weekly top-up sessions. And also, if you think about it, if we can increase the throughput of patients digitally or otherwise in these kinds of services, then those average cost differences will actually, you know, the difference in costs will go up and average cost per patient will go down. Okay, so next slide, please. So enter PrepWell. As we know, as previous speakers have said, this was extended. It was a much wider package with behavioural change as well as exercise. And we started off with quite a sort of, I suppose, a galloping rate, and then COVID hit, and then it's obviously, as we've seen, it's impacted on sort of throughput and the direction of PrepWell as well, to include digital. Now then, what I've done here is compare vascular patients for the first 2 years of PrepWell with the AAA HIT intervention and control group. And what we see for PrepWell is that the health-related quality of life improves even more when you bring in behaviour change than just the exercise in AAA HIT. And also really encouraging that lengths of stay is lower again than the AAA intervention. So we're now down to a median of 6 days. So there's a difference in 3 days across the intervention and the control, which we say on average £250 per bed day, the savings can be quite considerable. Next slide, please. So then we turn our attention towards, obviously, the Go Well Health platform. So as Paul has briefly talked about, sort of the joint recovery school, the Go Well Health platform. And what we realised is we had a good opportunity here to look at the impact of the Go Well Health platform, that digital, is it digital joint school? I'm getting the name wrong. On patients who'd undergone knee replacement. And why did we have an opportunity? Because we had NHS PROMS data, so for orthopaedic surgery for hips and knee replacements. This is a mandated programme where health-related quality of life is collected prior to surgery and post-surgery. And we had an opportunity here because we had patients who had activated and engaged with the Go Well Health platform and those that didn't. So in a sense, we had a natural experiment or a potential comparative cohort study. So what we did was we looked at over 2,400 patients who underwent these types of surgery at the South Tees, and I can't remember what, and anyway, James Cook Hospital through 2018 and 2019. And what we did is we had the PROMS data, the Oxford Hip and Knee scores, and the health-related quality of life scores for those patients. And what we did is we linked that to HES data to get length of stay, socio-demographics, comorbidities for patients themselves, so that we could actually start controlling for in the analysis for the differences in the two types of cohorts. So we compared, as I've said, clinical outcomes of hip and knee. We compared EQ5D, related quality of life, and we also looked at length of stay. What did we find? If we can just go to the next slide, please. So the Go Well Health results, there was improvement in quality of life for both knees and hip patients relative that engaged with Go Well Health relative to those that did not. These were statistically significant improvements. And in fact, length of stay for hip replacements in particular was 36% lower for those patients that engaged with the Go Well Health platform than those that didn't. And so we saw post-operative functional Oxford Hip and Knee scores much higher. So what I'm saying here is we have an improvement in effectiveness, in clinical effect, in health-related quality of life, whilst being able to achieve some efficiency savings with reductions in length of stay. So final slide, please, just some concluding comments. So these findings are encouraging. We've got improvements in post-operative PROMs, as I've suggested. We're seeing reductions in length of stay as the research trajectory is going forward. And there are cost savings to be had in terms of bed days, and that it's not just about length of stay, possibly readmissions. If we see these improvements in hip and knee surgery, which has actually been the focus of reductions in length of stay over the last 10 years, we think the efficiency savings possibly will be a lot higher for higher risk surgery areas. In terms of future research, sort of looking to the future, what are we going to do next? We're going to actually compare Go Well Health and Prep Well together, all right, for patients who engage with those and patients that don't. So that's over the next 2 years. We're waiting for the numbers to increase. And we'll also be looking at readmissions as well as length of stay. We'll go back and forth and look at previous, so the orthopedic data, but also following going forward readmissions. What we also plan to do is look at the PROMS data that we've talked about for orthopedic surgery to highlight the reasons, what was going on, why patients didn't choose to activate the Go Well Health platform. And we're fairly certain that's down to comorbidities, age, etc. But that's something that we'll be moving our attention to in the next couple of months.
Okay, Joe. Yeah, that's brilliant. Thanks very much. We're just going to have to play a little bit of catch up in the Q&A, I think. But thanks very much, Joe. That's great. Really interesting presentation. Can you just mute your microphone again, please?
Yeah.
So next, we're going to move on to the final presentation before the Q&A session, which is going to be done by Dr. Neil O'Brien, and it's a system approach to waiting well in the North East and North Cumbria ICS. Neil is Chief Clinical Officer and Accountable Officer for 3 CCGs in County Durham, Sunderland and South Tyneside. He's been a local GP in Chesterley Street for over 20 years, and he has a special interest in cardiology and has previously worked as a GP with a special interest in this area. So more information is available about Neil's biography on the website. So we're going to move forward to a pre-recorded final talk. Thank you.
Hi, my name's Dr. Neil O'Brien.
I'm a GP in County Durham, but I'm also the Chief Clinical Officer for 3 CCGs in the North East and North Cumbria ICS. And I've been asked by the ICS to oversee a project on waiting well or preparing well for surgery. I'm going to talk a little bit about that today. Just to say, I'm not an expert in this area. I am a commissioner and a GP. Others who are much more informed in this area have been part of the task group developing some of this work, and a lot of credit has to go to those, and they come from lots of different backgrounds across the ICS. The scope of our work is to look at patients who are classed as P4 on the waiting list. Therefore, by definition, they're able to wait for longer than 3 months or more for surgery. But as we know, with the current state of the elective waiting list, some patients will expect to wait 12 to 18 months for surgery. And it's our aspiration to try and get them as fit as possible for surgery and to reduce unnecessary cancellations. So as I mentioned, lots of people have been involved in this work across the ICS, and actually we've also been in touch with colleagues in Yorkshire who are a little bit more further ahead in our thinking on this. But we've had clinicians from primary, secondary care, commissioning leads, public health, and then data help from the North East Commissioning Unit to try and help us get to where we are at the minute. So the principles is that we are looking to provide equity, not just equality, try to get reduce health inequalities and try and level up. So we've got a real focus on those who are more vulnerable and deprived in our populations, as their outcomes are likely to be worse if they're waiting longer for surgery. We've tried to use evidence-based where possible and try to use existing services and integrate them into this model rather than commissioning new ones. So our approach broadly is to take the whole population of those who are on the P4 waiting list and risk stratify them, and to try and pick out those who are at greater risk of adverse outcome. So we think they are those who are most deprived, individuals with learning disabilities, certain ethnic categories, diabetics and smokers, and then there's the group of everyone else. Now you can use different kind of risk categories to screen the population, and that can be quite easily done with the data tool that NEXT have developed, but these are the ones that we think are most important. Those who are in the higher risk group would get a contact by a central hub, which would be in the form of a letter or email, followed up with a phone call, and then a personalised care assessment, including a PAMS assessment, would then channel people into 3 broad offers of support, which is complex, targeted, and universal, and we would envisage that they would be delivered very close to people's home. So the complex is mainly those that would be the top of the pyramid, a small number relatively, those who need possibly face-to-face clinical help managing chronic disease, such as diabetes or hypertension. Then there's the targeted approach, which are those individuals who potentially have low PAMS scores or are in the more deprived population, and they would have a targeted approach, which would be followed by local services such as a social prescriber. And there's a universal offer, which would be for all others who are deemed to be quite motivated, and all they need is access to relevant information to help them prepare well for their surgery. So I mentioned the risk stratification dashboard. It's based on GP record data, and it's integrated with the hospital trust's waiting lists. That's just an example of this. I know this is quite small, but it just gives you an idea of the level of information that we have, and it can drill down to NHS numbers, so we can quite easily identify individual patients. We've thought developing a central hub approach for the coordination of this is the preferred option. We do have a very large ICS that would help to roll this model out equitably across the ICS, and also there's not a great deal of capacity currently in secondary care or in primary care to coordinate this model. So we think something new has to be put in its place. Again, the programme of support, as I've mentioned, really does look at the whole person. It looks at basically the wider determinants of health, and then the offer is very much targeted to either support for self-management, social prescribing, and digital offers. The bespoke social prescribing offer is targeted at those most vulnerable groups, and there is some evidence of some success in a Newcastle model, which I'll talk about in a minute. But the wider determinants of health, we're really looking at the causes of the causes of risk factors. So that's social isolation, poor housing, low self-esteem, poverty. See if we can bring other agencies in to try and help the individual and get them in a better place. We understand that prehabilitation is not just exercise, it is about controlling other modifiable risk factors. We're focusing on diabetes and smoking initially, but high opiate use, cancellations due to suboptimal anticoagulation, unidentified sleep apnea, frailty, are just some others that we have also thought would be relevant. This is a story, just you'll all recognise it. Pre-assessment clinic, patient comes along, their HbA1c is 97. We've tried to contact the patient, we finally get hold of them. They go to their GP, they have a slight increase in their medication, they then come back again, their HbA1c is a little bit better, but not quite on target. They've been referred to the diabetic clinic, and it just takes months and months and months. In Newcastle, there's a pilot of a social prescribing intervention from HealthWorks, which basically picks these patients up and puts them through a 12-week programme. This has been proven to improve pre-operative HbA1cs and therefore reduce cancellations at a relatively moderate cost. The cost of this is more than covered by any reductions in cancellation. We've talked about a digital offer. We've talked very much about tiered digital offer. So universal, which is reading material, targeted, which is about questionnaires and which is personalised to the individual, and then complex, which is very much tailored towards an individual, and it could be kind of virtual support as well. The costs of those, obviously universal is relatively cheaper than the others, but we're pretty certain that these modes of communication are both improve accessibility and are cost effective, and they're all in development at the moment. So we think the total indicative cost for the whole ICS is about £1.2 million, but if we get most individuals through this, as you can see, the potential productivity savings are just over 800,000. Our measures of success would be about reductions in cancellations, improved PAM scores, improved diabetic measures before surgery, and we'll look at those measures both in the at-risk groups and the population. Our risk is the sheer volume of people, data quality, as always, capacity in our local social prescribing services in order to meet any demand, the finance, and if we don't get the model right, we could actually worsen health qualities. Our next steps is we're attempting to secure some finance, commission a stable and recurrent offer, so that this is just not a one-year thing. This is part of the normal day job, and then we'll evaluate share level. So that's been a very quick rattle through. I've gone 1 minute over my time. Happy to take any questions later on in the session. Thank you.
Great. So thank you very much. Thank you very much, Neil. So essentially, that's the end of the kind of the presentations and the program, and we now have just under 30 minutes to open up the floor to kind of question and answers before summarising and kind of discussing what the next steps might be. So I guess the Q&A format is going to be similar to before the coffee break. So you can either ask your question directly by putting your hand up, or you can post it in the chat box and somebody will bring it to my attention, or I'll try and see it. It looks like we've still got Dave, Apprentice and Sue Hackett available for anybody who is keen to explore their experiences in more detail. So without further ado, the floor is open for questions. Thanks very much, James and Neil. I think we're in the last 5 minutes now, so I probably just want to summarise and start to close the meeting. We have opportunities for next steps. If anybody has any ideas about developing this theme further, Fuse would be interested in engaging with us to support further work. I think that would be good. We have the opportunity to showcase further some of the face-to-face, some of the digital work, anything that anybody thinks, please put in your feedback. I think there is a feedback form available, which would be very grateful if everybody on the call would be prepared to spend a few minutes filling out, which does include next steps. I would just like to thank all of the speakers for, taking the time to, through the summer holidays to do their pre-records, which, not always easy just speaking to a computer and doing that. So thanks for taking the time, and pretty much everybody's stuck to time, so that's been brilliant. Thanks for all the delegates who have joined us. Hopefully you found it a thought-provoking session. Clearly, we have made some ground. There's some really great work going on across the region that we've been able to share with each other. But as we've been hearing towards the end, there's still a long way to go. And thanks very much to Fuse for hosting this and giving us the opportunity to pull this program together. So with that, I think in the chat, the link's been posted. So if anybody could take the time to do that. And I think on screen there, Laura's just put some other upcoming Fuse events for anybody who's interested. And hopefully you've enjoyed it all. So so over and out, I think. Thanks for joining us, and hope you've had a good morning. Thank you very much.